And I am now recording this training as well so that we will be able to share this on our Facebook page and also we're going to put it on YouTube. So I think we're good to go, everybody. Ready to get started? I want to welcome you all today to our program, Epilepsy Equity for African Americans and the Treatment of Epilepsy. My name is Beth Stivers, and I'm the Director of Education at the Epilepsy Foundation of Kentuckiana. And this program, I'm going to talk a little bit about the program as well as the grant that has allowed us to bring this program to you. So today you are joining us for Epilepsy Equity for African Americans and the Treatment of Epilepsy. And we know in 2020, the conversation was started about systemic racism in our country. And it was focused a lot on the police system as well as in the education system. But we all know that systemic racism happens everywhere. And one of those places would definitely be the American healthcare system. The racial disparities that are present for minority groups, and in this case, we are focusing, our grant was focused on African Americans, but this does affect other minority groups as well. But it causes individuals to have unequal access to healthcare. So just to give you an idea of the inequity in healthcare, especially in epilepsy and African Americans specifically, there are around 375,000 African Americans that are currently living with epilepsy, and more than 20,000 newly diagnosed every year. African Americans are also more likely to be diagnosed with epilepsy in the emergency room than white Americans, and we know that would definitely affect treatment outcomes for individuals of color. They're more likely to develop epilepsy over their lifetime than white Americans, more likely to experience uncontrolled seizures, and also more likely to experience status epilepticus. So when we have discussions about systemic racism in the medical field, I know that it can be a very difficult conversation to have. And especially for those of us who are white, most of us would want to say, no, we're not racist. We would not want to admit to being racist. And I don't think many of us are actually intending to be, but due to implicit bias, we have ideas and stereotypes that in our subconscious, unconsciously, we accidentally move forward in our lives with this bias. And it does affect the outcomes for people of color, African Americans, and especially in the medical system. So today's program is designed to make sure that, especially in the treatment of epilepsy, we are looking to end that bias and that we are providing epilepsy equity for African Americans in treatment. So before we turn over to the panel, I want to talk a little bit about the program that we've done that has brought this to you. The program was funded through a minority outreach grant from the National Epilepsy Foundation and the Centers for Disease Control and Prevention. We were very fortunate to receive those funds. It has allowed us to reach out across the state and obviously through this program beyond to other states to be able to share the message and to raise awareness of epilepsy in the African American community, as well as try to promote, and the hashtag epilepsy equity was what we have been using to try to push that forward. So the program goals for this grant, we designed a PSA that will be aired on local and network television and radio stations throughout Kentucky and Southern Indiana. We're really hoping to push that through during Black History Month in February as well. We had bus advertisements in Lexington, Kentucky and Louisville, Kentucky, which are our two largest markets. We reached approximately 1.8 million individuals through these ads. So we're super excited that this was such a lucrative advertisement campaign for us. We provided seizure first aid certification programs for African American individuals, as well as staff among organizations that serve African American individuals and also the general public. This program was designed by the National Foundation, and much like the CPR certification, we provide seizure first aid certification so that we can ensure that individuals in the community are receiving adequate first aid when they have a seizure to keep them safe. And we've trained to date over 200 individuals using that training program. And then lastly, the goal is to provide the training program that you all are participating in today, which we are very glad that you all are here to start this conversation to ensure epilepsy equity in the treatment of African Americans with epilepsy. So you can see here, I'm just going to quickly show you our 30-second PSA just so you can see that, and then you can see pictures of the bus ads as well. But here's our PSA.
Any one of us can have a seizure. 1 in 26 will be diagnosed with epilepsy in their lifetime. African Americans are more likely to develop epilepsy than white Americans. More than 20,000 new cases of epilepsy are diagnosed among African Americans each year. Learn the 3 simple steps of seizure first aid. Stay with someone when a seizure occurs. Keep them safe. Place them on their side without restraint.
So we are hoping that that PSA will not only raise awareness of epilepsy in the African American community, but also epilepsy awareness in general statewide, as well as awareness of the Epilepsy Foundation of Kentuckiana, because we are here to provide services for individuals with epilepsy, as well as obviously African Americans are included in that. So that has been the bread and butter of our program. And so today's program that we are hosting, we have a panel here for you today. And I'm just going to let everyone know who is on the panel. And then I'm going to introduce Meriem Bensalem-Owen, who will then introduce our next speaker. But Meriem Bensalem-Owen at the University of Kentucky, Dr. Carey Ruiz at Campbellsville University, Dr. Ebong at UK hospital, or the Neuroscience Institute, Rachel Ward Mitchell at UK, Trenika Mitchell, she's a pharmacist at UK, Regina Hamilton, she is a professor at UK, and then Deb McGrath, our executive director, and then myself. So I'm gonna stop sharing my screen, and I'm gonna introduce Dr. Meriem Bensalem-Owen, who is a professor of neurology and the director of the epilepsy program at the University of Kentucky. The University of Kentucky program is a level 4 National Association of Epilepsy Centers, or NAEC program. This level represents the highest care for the evaluation and management of epilepsy patients. Dr. Bensalem-Owen is the director of the only ACGME accredited epilepsy fellowship in the state of Kentucky. She's also a board member of the Epilepsy Foundation of Kentuckiana. We're very glad that she is. She received several awards and recognitions at the regional and national level for her teaching and advocacy work, and she's also the current secretary and treasurer of the NAEC. So we are certainly glad to have Dr. Bensalem with us today, and I'm going to turn it over to her. Thank you.
Thank you very much, Beth, for this kind introduction. And also congratulations for securing the funding for the program. This is I think a wonderful program and a great opportunity to discuss, systemic racism and also, address it in the epilepsy population, more precisely for African American with epilepsy. And I'm really so fortunate today to be surrounded by remarkable colleagues from the panel that you just introduced. And I'm confident that the work and dedication of any member of the panel really will leave a durable legacy in the state of Kentucky, but we see that we have colleagues who joined us from outside of the state and the region. I would like to welcome everyone and thank you for being here. I would like to introduce our first speaker today. And so the first speaker is Dr. Carey Ruiz, who is an associate professor of sociology for the Division of Social Science and the director of diversity and community at Campbellsville University. She holds a PhD in sociology from the University of Kentucky. Dr. Ruiz specializes in social inequality, specifically race and social class. Her research interests have included public perception of welfare recipients, an evaluation of impoverished women's reproductive choices, best practices for teaching about race and reactions to racism. Dr. Ruiz has led several discussions in her community, as well as at the university level, with students groups discussing race and relations. She will share the historical perspective that led us today. So Carey, if you would like to take over.
Thank you very much. And thank you everyone for sharing your time with us this afternoon so we can have this conversation. As my introduction suggests, I spend a lot of time talking about inequality and issues of race and social class and some gender. And my experience with this is that when people ask me what I do or what I research, I explain to them and the response is usually, oh, followed by a quick change of subject, okay? So I want to echo Ms. Stiver's comments at the top, that this can be a very difficult and uncomfortable topic to grapple with and discuss. There are lots of reasons for this. Sometimes people have unreconciled issues and bias that they're not willing to dig into and address. Sometimes it's just that people are afraid they'll make a verbal misstep and say the wrong thing. But oftentimes people, perhaps personally, don't feel that they have individual bias against another group. And these things may be true. Now we know that there are plenty of studies out there that suggest that people do hold personal bias. And even in the medical field, there are some studies that indicate that among medical students that there's some misperception of pain tolerance. We also have the tragic example recently of Dr. Susan Moore, who publicized her video just prior to her death as she's dying of COVID and highlighting the discrimination that she's receiving. But I'm a sociologist by trade, so I tend to look a lot at the bigger picture, which means that I focus on social structure. And so despite someone's or anyone's best intentions, when it comes to race bias can still exist because the other side of the conversation, what other people or some people tend to overlook, is that it also exists in culture and social structure despite our best intentions or despite our personal bias. And so I wanted to share with you today a couple of examples. And, if I could quote Shakespeare, the past is prologue. And we know that we have a history in our country of bad ideas informing bad policy. And this also includes policy in the medical field as well. And so one of the examples I wanted to highlight today is the eugenics movement in the United States, which these ideas that propelled the eugenics movement culminated in a policy in the United States of coerced sterilization. It lasted about 50 years and before it was finally overruled by the Supreme Court in the late 70s. But this began with the Supreme Court decision in 1927, where they allowed for the first forced sterilization of a young woman by the name of Carey Buck, who was an epileptic. So there is this relationship with epilepsy and social stigma. Now, Carey Buck was a white woman, but the use of forced sterilization was really perpetuated a lot on people of color, Black women and Indigenous women. And so a lot of the eugenics language, which started with the idea of quote, feeble-mindedness, was also tied up to race. There was a lot of racial language included in that. Further, we had the example of the Tuskegee syphilis experiment. This experiment ran from 1932 to 1972, where Black men were deliberately infected with syphilis and studied to see the outcome. We're all familiar with this, but what's interesting is that what stopped this experiment in 1972 was a press release rather than the recognition that it was just bad policy and bad practice. So it's important to recognize, as we're having this discussion, it's important to recognize that historically and today, people of different racial demographics can have very different experiences with healthcare. And we need to be mindful of these experiences when providing care, and also recognizing that suspicion of healthcare is not without precedent. It's not without warrant. And oftentimes what we overlook when we only focus on the personal bias that someone holds is that racial bias doesn't always have to be the intention in order to be the outcome.
Thank you very much, Carey, for sharing that perspective, the historical, which will said basically tells us the story, the current story as well. I think it's important to understand what happened and again, the mistrust that we see in patients with epilepsy, African Americans, towards management and treatment when we approach treatment and management for them. So with this, I would like to introduce our next speaker, who is Dr. Mitchell. So Dr. Mitchell is a colleague of ours at the University of Kentucky. Dr. Trenika Mitchell received her Doctor of Pharmacy degree from the University of Mississippi. And upon graduation, she completed a pharmacy practice residency at the University of Kentucky Chandler Medical Center. She's an associate professor at UK in the pharmacy practice and science department. She is the assistant dean for diversity and inclusion for the College of Pharmacy. She also works as a clinical staff pediatric pharmacist at UK Children's Hospital. Dr. Mitchell very graciously accepted our invitation to share her experience as an epilepsy patient. Thank you, Dr. Mitchell. The floor is yours.
Thank you, Dr. Bensalem. She says I graciously accepted, but she's my physician, so I wouldn't be able to get my prescriptions if I said no. So I think I felt the need to go ahead and accept regardless. But no, I'm actually very happy to be here today. It's interesting to be on this side of Zoom where I'm being the patient rather than kind of being the teacher. That's what I'm normally accustomed to being. But it's definitely been an interesting experience. So as Dr. Bensalem said, I'm a pharmacist, so you're very accustomed to being in control, right? That's and if you want to find control fanatics, that's pharmacists. It's just who we are as a people. And so you're accustomed to that. But the time that I'm not is when I am having a seizure. And thankfully it's been over 6 years since I've had one. Thank you, medicine. That's really helped me figure that out, to be able to figure out the best way to prevent those. But it's a time where, so I spend my days being an advocate, right? Being an advocate for patients with my family. They're not very well versed medically. So it's very funny. I'll be at work and then I get this phone call and then I just hear and they're at with a physician and they want me to listen and to, just kind of be able to help them with questions. But I can't be an advocate for myself when I've had one, because I'm pretty out of it, which can be difficult. It took me a while. It was a long journey to figure out that it was seizures. They started at the beginning, in my early 20s. So, around pharmacy school time, which I'm sure stress didn't help that at all. And we knew that all we knew is that my mom looked like that. Like she did things that looked like me when I was having one, but they thought for the longest time it was a cardiovascular issue. So I saw cardiology for a long time. And then we finally, kind of came, determined that it was seizures and we started the seizure meds. But when I think about kind of my experiences with the healthcare system, there have been some really great ones. Again, I have an amazing neurologist, but, in some of those more emergent times, again, when I'm not able to be the best advocate for myself, it's been pretty difficult. And, I've shared with some of my colleagues before, probably one of the most frustrating times I can think of is I had, again, we thought it was it was a cardiovascular issue. And so I'd had, had just been with my physicians. They'd done an EP study and all of that. And so the next day I just felt horrible and it couldn't, things I just kept going in and out and it was really bad. And so we called and they said, you need to go to the ER. And so my brother, he takes me to the ER, but of course, you have to park, and so as I'm going in and I'm trying to get people's attention and no one's listening, and then the next thing, there's this, I can kind of hear at this point, this lady talking, I couldn't really tell what she was saying, and I was, pretty out of it. But my brother, he basically comes in from dropping me off at the door to seeing me on the floor of the ER, and this nurse is yelling at me, and she's yelling, "Get up! You can get yourself up. You're perfectly fine. Get yourself up." And so, so my brother, he was telling me later, he was like, she's not really understanding what you need her to do. She's, just, please stop yelling at her. And she was like, no, she's fine. She needs to get up. And then, a nurse's aide, she comes in to help me. She comes with a wheelchair and she tries to help me up. And the nurse says, don't help her. She can get herself up. And, and at that particular time, and so, and anybody that knows me, they know that I'm a germaphobe. So me ever intentionally lying on an ER floor is never going to happen, right? So it, wasn't intentional at all. And so kind of as we progressed through that visit, I, was watching people go into the ER, they were leaving, and it just continued to happen. And I was there for about 8 hours. And then I finally left because I was never seen at that time. And, and I was just like, you know what? I've lived this long through these 8 hours. I'm just going to have to hope I make it through the next, however, and I'm going to go home, because again, at this point we thought, it was a cardio issue. And anyone that's had a seizure can tell you feel horrible after you've had it. You just feel horrible. And so to sit there, for all of that time, and all you want to do is sleep. That's all, that's the only thing that's kind of on your mind at that time. And, and so, but I can just remember later on just being very frustrated, with that experience. And I ended up talking to someone. I didn't call them, but someone else did, because they were frustrated with the experience, from the ER. And I can remember the first thing he said to me was, well, did you tell them that you were a pharmacist? And, the reply was, why did it matter? Why did it matter whether I was a pharmacist, whether I had a job, I didn't have a job? It shouldn't have mattered, but somehow that should have made it, if I would have told them that, I would have been treated better and wouldn't have been treated that way. And, and so he was like, well, here's my card. And so if you ever go in, again, please call me. And I was just like, I shouldn't have to call you so that I can be seen, at the ER. And the only reason why I went was because I was told to go. So it wasn't even my idea to go. I was told by my physician to go. And before he left, though, I asked, because I knew the nurse was a triage nurse. And I said, I want you to be very honest with me. Did she have the ability to determine when I would be seen and how long I would sit there? And he was like, absolutely. And so, and so basically she just arranged it where I would just sit there all night long, never go. I have no idea what the problem was, or, why, I never try to make assumptions about someone's motives, but, it was just a difficult time, because I have such a faith in the healthcare system. I'm a part of it. And I, and I encourage people to use it. And, and I've just seen, and that's not my only time, there've been many others, but that's just a good example, but, of how it can be misused. And I think about, for me to be a person who does have a voice and knows how to advocate for myself, what's happening to all the people who don't know how, right? And don't know how things work, and don't know the person that they can call, and and so it's just which is why my family does call me when they go, because I just want to make sure that they're okay. And I know there are a lot of really great people out there. There are a lot of really great doctors, a lot of really great nurses, and other healthcare providers, but it's unfortunate when you have some who do not take our oath as healthcare professionals seriously, and treat people with the respect that they need. So that's my one. I'm sure others have other stories to tell, so I'll let the next person speak.
Thank you, Dr. Mitchell, for sharing this. It's very, very difficult. It's very painful to hear your story, your experience. And sorry if this had to bring you back to many years back to relive it by telling it, but thank you for sharing it with us. And I think, at the end, we will take questions and with the panel and everybody from the panel. So thanks again. I would like to introduce now my colleague, Dr. Ebong, Dr. Ima Ebong. who is a colleague from my division, not just the department, but the division of epilepsy. So Dr. Ebong is an assistant professor of neurology and clinical neurophysiology at UK. She practices both in epilepsy and in the epilepsy division, as well as the neuromuscular division. She's also the director of diversity and inclusion in our department. And I just wanted to mention that she joined the department about a couple of years ago, and she has accomplished so much. She's just done a fabulous job at the regional level, local, regional, but also national level. Dr. Ebong's interest in equity, diversity and inclusion started really in medical school, when she was in medical school. And about a decade ago, she created the University of Kentucky Medical Education Development, or UK Med. UK Med is an annual recruitment program for prospective medical students from underrepresented backgrounds. She's a founding member of the American Academy of Neurology, or AAN, Underrepresented in Neurology section. She serves on the AAN Specialty Commission on Racism, Inequity, and Social Justice. She's a graduate of the AAN Diversity Leadership Program and is a member of the AAN Diversity Officers Work Group. And I would like to welcome Dr. Ebong to the virtual floor.
Thank you so much for the introduction, Dr. Bensalem, and thank you for having me on this panel, and welcome to everybody who's participating. I have a few slides, and so Ms. Divers will pull them up and we'll get going. All right. Thank you so much. Okay. All right, so I have a few slides talking about some data that we have regarding the treatment of African Americans in particular who have epilepsy. I'll give some general information about neurology and some of the disparities that we have in our field, and then talk about what the data shows from as far back as the 1980s up until now regarding the inequity in treatment of epilepsy in African Americans. So why disparities? So this article was published in the New York Times last year. Dr. Ruiz and Ms. Divers had mentioned that really 2020 highlighted the inequities and racial disparities that we see in medicine. And I just want to reiterate, this isn't anything new. These disparities have been going on since the time of slavery in this country. It's just that, you know, with COVID-19 highlighting the racism experienced by African Americans in particular, we saw the differences between rates of infections and rates of death in that community. We saw so many articles being published on racism in medicine, but again, to reiterate, this is not something new. So this is just one article that was published in the New York Times talking about bad medicine and the harm that comes from racism. So a little bit of data on the geographic distribution of neurologists. So one of the reasons why we have disparities is because neurology as a field, we are one of the, we're not one of the most popular fields, I should say, when it comes to medicine. Most medical students don't go into our field. And so as such, there are parts of this country where there are not enough neurologists to treat the patient population. So if you compare statewide, California has the largest minority population, but there are only about 4 neurologists per 100,000 people there. Compare that to the Northeast, especially in Massachusetts. For instance, the state of Massachusetts is less diverse, but they have 8 neurologists per 100,000 people. If you look at the Southeastern United States, it's home to the largest population of African Americans in the country. As a matter of fact, more than half of the US Black population live in the South, but there are fewer outpatient neurologists per capita compared to that of the Northeast. So you can see just from the color scheme, the lighter green in the Southeastern United States compared to the darker green, which shows that there are more neurologists in the Northeast where there are fewer African Americans. And I don't have a slide talking about this, but this is another thing that I wanted to bring up. We also see in comparison to the general population of Black people in the United States, there is a discrepancy in the number of Black neurologists. So for instance, in the United States, about 13% of the population is African American or Black, whereas the percentage of Black neurologists, most recent data shows is somewhere between 2 and 3%. So again, you see some discrepancy there as well. So Ms. Stivers had mentioned earlier about how African Americans are more likely to be treated for epilepsy in the ER. And this is true today and was true over 30 years ago. So I pulled up some data from a paper that looked at racial and ethnic disparities in the treatment of epilepsies from as far back as the 1980s going up to 2000s. So I highlighted some things that are still relevant today. So you can see this paper published in 1989, 79% of patients were Black who presented to the emergency department for seizure visits. And they found in the same study, only 14% were receiving anti-seizure medications and 57% had subtherapeutic anti-seizure medication levels. And another study documenting hospitalizations for epilepsy, the age-adjusted rates were lower for whites than for all other racial groups combined, 35 versus 51 per 100,000. So again, compared to white people, non-whites were more likely to be hospitalized for epilepsy. And then hospitalizations for epilepsy, compliance. I don't really want to get into this talk due to time, but I prefer not to use the word compliance because it places blame on patients. I talk about barriers to treatment, but nonetheless, 85% of the patients were African American or Hispanic when they were hospitalized for whatever barriers to their or their ability to adhere to treatment. This one is a more recent study. We showed the one in 1989, but again, in 2004, again, African Americans were more likely to go to the ER for treatment of their epilepsy. And then another data point that was interesting from this paper was anti-seizure medication and psychotropic drug use. So fewer Black students, and this is in a student population, so fewer Black students were receiving medications compared to their white peers. So these are just examples of the disparities we see for decades now regarding treatment of epilepsy in African American populations. Another reason why the disparities is distrust. So there was one article that I reviewed. It was from an epilepsy foundation in another state that had a focus group. And in this focus group, they had 10 African Americans, and then they had patients from other ethnic and racial groups. But what struck me from this paper were some of the things that I read that were said during the focus group. So one, even though all of the African American participants were recruited from the Epilepsy Foundation and received the Epilepsy Foundation newsletter, only 3 of the 6 knew what type of epilepsy they had. Additionally, one African American patient who was interested in joining the Epilepsy Foundation support group voiced their discomfort in participating, saying that not being negative or anything, but they were older and white, and I was Black. So there's some discomfort there as well, being in a setting where you feel that you may not get the same treatment because of your race. And then in this paper, many of the African Americans described distrust in their healthcare providers. The reason why I put this book here, I don't know if any of you in the group have read it, but I implore everyone in the medical profession, but actually anyone in general, to read this. The book is called Medical Apartheid: The Dark History of Medical Experimentation on Black Americans from Colonial Times to Present. The author is Harriet Washington, and this book details accounts from slavery up until now of the experimentation and the poor treatment that was given to African Americans in this country regarding healthcare. Dr. Ruiz talked about eugenics. She talked about the Tuskegee experiment and numerous other experiments that were done to Black people. And she describes this in detail in this book. And I think that it's important for medical professionals in particular to read this book to understand why there is still distrust in the medical field to this day. And we need to reconcile that so we don't do it again. To bring things to the current, to current issues, there are many African Americans who do not trust the vaccine because of what has happened in the past in this community. And I think understanding the past will help medical professionals empathize with our community more and be able to move forward and treat them as they should be treated. And just listen, I'm a little bit still shaking because I have goosebumps from Dr. Mitchell's account of how she was mistreated in the emergency room. And I can't believe that something like that still happens to this day. But then again, I sit back and I do believe it because we watched the video of Dr. Susan Moore. And even myself, I've had a negative experience in the healthcare field during childbirth that I've shared wildly with other people before. So Dr. Mitchell mentioned the fact that she's a pharmacist and she shouldn't have to tell people she's a pharmacist to get proper treatment. The same thing with me. I'm a physician. I shouldn't have to tell people that I'm a physician to get proper treatment. So I implore everyone to purchase this book. It's on Amazon and you can get it in any bookstore, but read it. Read the accounts of what was done to African Americans and she talks about other minoritized groups as well in this book. But this is something that I believe that everyone needs to read to understand. So I'm going to end here because the rest of the time really is going to be discussing how we can move forward and afford equity in epilepsy for all, or epilepsy equity for our African American patients. And I just want to end with this quote from Dr. Martin Luther King Jr. "Of all the forms of inequality, injustice in health is the most shocking and the most inhumane." Thank you.
Thank you, Dr. Ebong. This is very, thanks for choosing, that last quote. I think it's very difficult not to become emotional when we hear these numbers, when we hear experiences. And I know that Medical Apartheid, the book, I think you have it in your office and you have sent an email to the faculty and to the trainees to come by and borrow the book to read it. Thank you. Thank you very much for sharing these numbers and even your experience, personal experience. I would like to introduce now our next speaker, and hopefully we'll have some time later to ask questions to the panel or even share more experiences. So our next speaker is another colleague from the University of Kentucky, but from a different department, not neurology or pharmacy. So Dr. Regina Hamilton is an assistant professor in the English department and African American and Africana Studies program at UK. Her primary fields of study are the 20th and the 21st century African American literature and women's and gender studies. She has been diagnosed with epilepsy since 2013 and very kindly agreed to share her own experience as a patient with epilepsy. Thank you, Dr. Hamilton.
Thank you. Thank you for having me. Hello, everybody. I don't think I've ever talked to this many medical professionals in my life, so this is very, very interesting. Dr. Ebong is my current neurologist, and I have been very, very fortunate to find her. I, like Dr. Mitchell, have had some rather interesting and negative experiences as an epilepsy patient. I was 27 when I was diagnosed. This was my second year in my PhD program. So like Dr. Mitchell, I'm very, very positive that stress did not help that situation. I had no idea what was happening. I woke up in an insane amount of pain and called my mom in Florida. I was in New Jersey at the time. And she's like, you have to call a friend. And I went to the emergency room, as many apparently African-Americans do. And it took them, it took a while to figure out exactly what was going on, but I've had neurologists. I was never given a treatment plan. I was just told to take a medication and go, and they sent me on my merry way. I was given no information about epilepsy, about, the future of like how this could change. I wasn't given any information. And as an academic, I was, an academic in training at that point. I was a person who thrived on information and felt really, really sort of offended and sort of, really just kind of at sea with this diagnosis. I had nobody knew had epilepsy, no one in my family did. And so I had no idea what to do. I saw another year, in the future, I saw another neurologist who told me the only treatment they give me was surgery. She wanted to remove an entire lobe of my brain. And I didn't know what to do with that, but I refused that. Glad at that point I had moved home to Florida, and I was glad my mother was there to help me advocate for myself. I had another neurologist ask me whether my epilepsy was brought on by using drugs. And I was like, I don't know what that even means. I don't even know what you're talking about. I'm just trying to figure out what I should do next. So I've had several negative experiences as an epilepsy patient, which is why I literally thank God every day for Dr. Ebong. And I know for a fact, I've met other epilepsy patients. They have had, a lot of my friends who are not Black have not had similar experiences in terms of even just trying to find a neurologist that will sort of give me information, a treatment plan, explain to me what's happening, just information, right? And so it's been difficult, but I have a treatment plan now, though. Thanks, Dr. Ebong. Yeah, so I'm happy to be here. I'm also, a professor of African American Studies, so I can second all the things that Dr. Ebong and Dr. Ruiz have been talking about. I teach my students often about, they actually are rather shocked, right? Because often, I'm a 20th and 21st century scholar, but often I have to teach, I teach from like slave narratives forward. So, the entire African American literary tradition, and they are often very shocked about the ways, the physicality of enslavement, right? The ways that people's literal bodies are tied up in our understanding of who is human and who is not, and the kinds of violences that can be perpetrated against the Black body. And that sort of is all over and sort of feeding its way all through our society still to this day. So I'll stop there, but thanks for having me. I appreciate being here.
Thank you, Dr. Hamilton, for sharing your own experience. And yes, again, those are all painful, stories to hear, but I think it's important that we hear them, that we hear your perspective, as we heard Dr. Mitchell's perspective. So thank you so much. I would like to introduce, I think, so we will have, let's see here, so the next one, so I can be on schedule. So I would like to introduce my colleague and friend, Rachel Ward-Mitchell. So Rachel is our epilepsy nurse coordinator for the epilepsy program at the University of Kentucky. Before assuming this position a little over a decade ago, she was a bedside nurse in our adult epilepsy monitoring unit. Rachel strives to raise epilepsy awareness and improve the quality of life of those living with epilepsy. She has provided invaluable and much needed epilepsy education to patients, their families, healthcare providers, nurses, and just her dedication is phenomenal. And so I consider her as my right hand She supported patients and their families in creating the Central Kentucky Epilepsy Network, and she leads our support group as well. Additionally, she organizes once a year an Epilepsy Education Day, and I would like to welcome Rachel so she can share with us all the resources that we can offer. Thank you, Rachel.
All right, thank you very much. Can you see the right screen here? I think.
We can see you, Rachel.
You can see me.
The panel, yes. Do you want to show us slides?
I do.
Slides? Okay.
There we go. I just didn't hit the right button. Okay. All right. So thank you very much, Dr. Bensalem, and thanks everybody who's already spoken. I have enjoyed this very much and am glad to hear different experiences. And I would add too that, you know, I hear stories all the time of people with epilepsy being treated inappropriately in the ERs all over, and it breaks my heart. And I imagine that we, you know, you add some sort of a bias in there, even beyond epilepsy, or, you know, just as Dr. Mitchell said, that, you know, she can get up, she's, you know, she's fine, she's faking it or whatever they thought. I hear that often. My role as the epilepsy nurse at UK is to make sure that people understand what they're going through. And I know that Dr. Bensalem, Dr. Ebong, my other team members are very good at identifying when people are struggling and pointing them to me. I do have a monthly support group, and I've had this support group running for more than 10 years. It's the first Tuesday of every month. It is open to anyone affected by epilepsy. So family members, patients, you know, or people with epilepsy. They do not have to be affiliated with UK at all. Any age. Normally, we would meet in the Health Education Library, which is in the Chandler Medical Center. But since the pandemic began, we have been doing Zoom. And I think it's a different, we're getting somewhat of a different group here and there, but we're able to connect with people who would not otherwise be able to make it to Lexington to these support groups. So it's been really nice to do that. And I think that, you know, when we are able to meet in person again, that we'll probably continue to do also some support groups via Zoom or some other platform. It is RN supported, and usually we have someone, Deb is often there from the Epilepsy Foundation. So that's a really wonderful support for us. We do have periodic special interest groups. For example, epilepsy surgery, pediatric populations, epilepsy 101. And those are geared to, you know, we try to pull in people that really could use more information or have questions, and I try to connect them with maybe some mentors during that time period. This is a closed group, so it's usually very small. People sometimes will bring their whole, you know, their whole family will connect. So it requires registration for a link and password. These are both the support group and the special interest groups are secure, password protected, and this is RN and physician supported as well. We also have the Central Kentucky Epilepsy Support Network, and this is, as Dr. Bensalem said, I put together with a group of patients and families this group that connects people in sort of a mentoring type program. It's informal, and we get together and we've done a lot of really fun social events. For example, we've done, you know, just very informal park picnics. We've done Picnic with the Pops, where we've decorated tables. We've done, you know, every year the Epilepsy Foundation sponsors a Legends game for us to all attend. And that's what this picture is. And then we have a member who has an annual farm shindig. It's an afternoon at their farm. We get to, feed the horses. Sometimes they'll let the kids get up on the horses and they'll walk them around. We have a bonfire and chili, and it's a really very fun event that I, as well as most of the members of our group, look forward to every year. We do have a Facebook page that people can connect with us that way. I put out a monthly newsletter for our support network, and I do have a mailing list, and the email is right here. If anybody wants that information, I mean, all you have to do is contact me, really. But you can go to Central Kentucky Epilepsy Support Network, and me and 2 other people keep up with that, the messenger through there. Let's see. We do have an annual Epilepsy Education Day. This year we sort of swapped that with some special interest groups that we did virtually. And I look forward to getting back to this event that we have every year in conjunction with the Epilepsy Foundation. We have tremendous support from University of Kentucky, the Neuroscience Institute, from our physicians who are amazing, and they come in and they will do special, topic discussions and special small groups where it's really a lot of dialogue and allowing people to ask questions about things that might be mysterious to them or that they don't understand. To the left here, that is our Central Kentucky Epilepsy Support Network at the Education Day. And then to the right is a large part of our group that we had when we hosted that at the W.T. Young Library. And I would like to say, we have an amazing group at University of Kentucky. We get out and do a lot of community outreach. We work closely with the Epilepsy Foundation, and this is from our EEG technicians to our nurses to our nursing care techs on the epilepsy monitoring unit, our physicians, surgeons, residents. And we even have, we have some other people. We have like our little guy that helps with transportation. We've got our staff on the epilepsy monitoring unit, and they all take the opportunity when they can to advocate for people with epilepsy. So we have a really, really great group of people here. And so hopefully, when you walk through the door, every person that you come in contact with that's involved in the epilepsy group should be able to offer you something. Comfort, education, a lot of even our technicians, our nursing care techs will point patients who are struggling to me, and we'll work on together on figuring out a solution to their problems. And thank you very much.
Thank you, Rachel, for sharing all these resources. And since we have colleagues that are out of state, and everything is virtual nowadays, so they're more than welcome to refer their patients to join the support group. So we would love to have people even from out of state. Very good. And with this, so we can stay on schedule, I would like to introduce our next speaker, who is the Executive Director of the Epilepsy Foundation of Kentuckiana. So it is my honor to introduce now Mrs. Deb McGrath. So Deb is the Executive Director and co-founder of the Epilepsy Foundation of Kentuckiana. Deb's daughter was diagnosed with epilepsy at the age of 33. At the age of 33 years ago. Okay, so 33 years ago, she was diagnosed with epilepsy, and she has dedicated the past 28 years to developing the foundation's vital advocacy, education, outreach, and direct support services to improve lives impacted with epilepsy. Deb has been recognized for her advocacy work by the National Epilepsy Foundation with the Excellence in Advocacy Award in 2002 and the Advocate of the Year Award in 2007. Many lives have been touched by her passion and conviction against the discrimination of epilepsy over the years. Deb, thank you very much for the work you do in the state of Kentucky and the region. And also thanks to your staff, of course, Beth with education. I know Beth travels a lot around Kentucky and the region and provides free education. Thank you.
Thank you, Dr. Bensalem. And thank you all to all of our panel members. I truly appreciate, Beth and I truly appreciate you being part of our program today. And I know that we're getting close to running out of time, so I'm just going to go quickly over a few things that the Epilepsy Foundation of Kentuckiana does to help in the treatment of individuals with epilepsy, specifically epilepsy equity for African Americans with epilepsy. So next slide. On behalf of the Epilepsy Foundation advocates on behalf of people with the epilepsies and their family members and caregivers to overcome the challenges of living with the epilepsies and accelerates therapies to stop seizures, find cures, and save lives. And our advocacy priorities are to ensuring access to quality health care that is affordable, physician-directed, and person-centered, ending epilepsy-related discrimination and protecting the rights of people with disabilities, promoting public health, education, and awareness about the epilepsies, and fostering biomedical innovation through incentivizing the development of new therapies and the promotion of research to gain a better understanding of causes, consequences, outcomes, and ultimately cures for all the epilepsies. So, and you know, we do that, and so many people are involved at the National Epilepsy Foundation, but it's not only the foundation itself, it is the level 3 and level 4 epilepsy centers. And in Kentucky, we are honored to have 3 level 4 epilepsy centers, the University of Kentucky, the University of Louisville, and also Norton Neuroscience Institute. And so the Epilepsy Foundation of Kentuckiana has developed a great relationship with all 3 of our level 4 epilepsy centers, and we're grateful for that partnership to be able to work together to help support individuals with epilepsy and to help advocate for them. The National Foundation has allowed us to really develop our advocacy program. And one of the programs that we work with is our Teen Speak Up program. And on the screen, you will see 2 young gentlemen who are Teen Speak Up representatives from Kentucky. And we have Charles and we also have Jackson, and they are there with Congressman Barr. And the Teen Speak Up program allows these young individuals to actually develop their voice and to work on a state and national level to talk about their epilepsy and to share their experiences with epilepsy. And so we're really thrilled to be able to offer this on an annual basis and develop their desire to continue to advocate not only for themselves, but also for others with epilepsy. So that's one of the programs that we do offer. Another program that we offer is our you can go to the next slide, Beth, thank you. Another program that we do in our advocacy efforts that we've been successful at is being the first in the country to pass landmark legislation with House Bill 147, also known as the Lindsey Crunk Act. And so this is, like I said, landmark legislation to where we created an educational program to educate school personnel on epilepsy awareness and also seizure recognition and seizure response. So it's the first in the country to actually do that. And this legislation also allows us to advocate even further for students with epilepsy and ensuring that they have a seizure action plan in their file, in their student's file. So that way the physician signs off on the seizure action plan and allows the teacher to actually, or the faculty and staff there to follow the guidelines that the doctor has provided for them in administering seizure first aid. And also knowing that this legislation also allows for any FDA approved seizure medication, first seizure response medication to be administered. And that is critical, especially for individuals, for students with epilepsy, to know that, that medication will be there for them, and that, that they don't have to go through their day and knowing what happens if I have a seizure. So that medication will be administered to them as prescribed by their physician. So we're grateful for the work that was done by a number of individuals that really focused on this legislation with us. And we know that we're grateful to have the physicians backing us with this legislation, because it was critical. So next slide. So we know that more people live with epilepsy than autism, spectrum disorders, Parkinson's disease, multiple sclerosis, and cerebral palsy combined. But silence, fear, and myths around epilepsy persist in every community, including African-American communities. And so I know Rachel talked about some of the programs that the Central Kentucky Epilepsy Support Network does. And we are honored to partner with Rachel and with Lorraine, with the Central Kentucky Epilepsy Support Network, and to provide individuals with the opportunities to come together, and that helps them feel like they are part of a community. And so we have a youth support network. It's called Youth Epilepsy Alliance. And one of the pictures here, we do a Build-A-Bear. We go to Build-A-Bear and offer our kiddos that opportunity to do different activities on a monthly basis, to come together. Another one is the painting that we did. So it allows them to express themselves, but also find comfort in their community together. We do an annual basketball camp for youth in Lexington and also in Louisville. And the goal is to make sure that we are providing that support network to them, to help them live as well as they possibly can with epilepsy. And we know that there are many barriers in place, and having access to care shouldn't be a barrier. We want to make sure that they have every right to medication, to the treatment, to surgical options, as much as possible, and coming together as a community and providing those educational opportunities, and also fun opportunities as well, to be part of the community with the Epilepsy Foundation is what we try to strive for every day. And we have Beth, who you've met, but also we have David Pettit, who works as our education coordinator in Western Kentucky. And they work together in providing educational programs throughout our communities, and not only in the school system, but also within our medical communities, because we know that's important. That as we've heard from Dr. Mitchell and also from Dr. Hamilton, that unfortunately epilepsy, many individuals within the medical community are not aware of, or that they don't understand the scope of epilepsy. And so that's our reach, is to educate and to provide that support to them. And we provide a certificate program, an epilepsy certificate program now. So if you would like additional information about the Epilepsy Foundation of Kentuckiana, please feel free to reach out to us. We'd be more than glad to help get you connected, or provide that support services to you or your patients. So thank you very much. And again, thank you to our panel for being here.
Thank you very much, Deb, for giving this overview of all the services and the accomplishments of the Epilepsy Foundation of Kentucky. And I think we accomplished, the foundation has accomplished several things that were recognized at the national level, which is fantastic. We're so proud of everyone's work in the region. So now we have, I think, the meeting was set up to last 1 hour. Is that right, Beth? And I have a few questions,
yes,
but I'll
Yes, there are some questions in the chat box, so I'll go ahead and read off one. And for the panel, it says, are there any hypotheses about possible neurological underpinnings of increased incidence of epilepsy in African Americans? So if there are any panelists that want to take that
Dr.
question.
Ebong is ready.
So from my research so far that I've been just reading and trying to understand, I don't see anything neurobiological. The reason why many of the studies say that African Americans are more likely to have seizures or develop epilepsy based on causes of epilepsy. So African Americans have higher incidences of stroke. So we see more stroke, for instance, this is just one example. So because of higher incidences of stroke, we know that strokes are actually the #1 cause of epilepsy in the elderly population. And so they relate the incidence of epilepsy in African Americans to the fact that there are more African Americans with stroke. Similarly, there's data about trauma, TBIs, all causes of TBIs. Apparently African Americans have higher rates of traumatic brain injuries and trauma in general. So some of the studies that I were looking at use that information to say that then they were more likely to develop seizures. As far as neurobiological, I've been reading and trying to study this for the last year, and I don't see anything that says that biologically we're different from other races that would make us inherently more likely to have seizures. So that's the answer that I have right now. And I'm sure people are trying to find something, but I didn't see any good information to show that there is a difference between us and anyone else.
There was another question. It said, are there pharmacotherapies for epilepsy that have greater or lesser efficacy in African American patients?
No, so the way we treat epilepsy, we pick the pharmacotherapy based on the type of epilepsy a patient would have. I don't see any data saying that there's one medication that's specifically for African Americans or one that I'm muted.
Sorry.
Did you all hear anything? Was I just talking?
It was just a quick
Oh,
flip.
okay.
Yes, ma'am.
There's no data showing that one medication is preferred over another. I know in other aspects of medications, of medicine, for a long time, certain antihypertensive drugs, for instance, were said to be just for African Americans. And we found recently that this is not the case, that we shouldn't pick and choose medications based on someone's race. You pick medications, one in our field, based on the type of seizure the person may have, and use that as the basis of your choice. And Dr. Bensalem could add in case.
No, that is absolutely true. Absolutely true. So the choice is based on the type of epilepsy, and then so we have about more than 20 anti-seizure medications. So type of epilepsy will determine that, but also the comorbidities and prior reactions to past medicines that were tried, allergic reactions, adverse reactions. So the choice will have an algorithm that's a mental algorithm. So we go down very quickly. After several years, everybody has that mental algorithm and we go down. So we don't have a favorite medication. I have several patients tell me, what is your favorite medicine? I don't have a favorite one. My favorite one is the one that's going to work for my patient. That becomes my favorite medication and the favorite medication for the patient. So the goal is no seizures and no side effects. We strive to achieve that. If we can't, then we have other options that we can discuss, that more complex that we can discuss. I don't know if you have more questions. Otherwise, I have a question for one of our panelists. But how can Beth? Do you want to go over have you been looking at the chat, or do you want me to take that one?
I have one. It says, how can a white physician work to increase trust in the medical system with African American patients, aside from really listening to them and explaining what is going on with them?
That is excellent, because I love this question, because I was going to ask this question to Dr. Ruiz or to Dr. Ebong, or even to Dr. Bitchell and Dr. Hamilton, because as patients, they may know what works. And of course, everybody's different, but they may. So anyone can take, anyone can take this question.
Initially, let me jump in first, and I want to defer to the others on the panel, because I really feel like I might be out of my wheelhouse a little bit. But I do think initially educating yourself, as you know, Dr. Ebong pointed out medical apartheid. I think that would be a good place to start, just to realize the climate, the culture that has been built up around this. And along with that, with the question of the neurobiological relationship, and this is where I feel like I might be a little out of my element, I'm wondering if Dr. Ebong could also speak to perhaps race-related stress in society at large. That the present, you know, we spent a whole summer last summer watching the, you know, African Americans get pummeled at the hands of police, and how that, and perhaps the indications of poverty and the stress of poverty, the stress of discrimination, and just the day-to-day life could also perhaps contribute.
Thank you so much, Dr. Ruiz. And I mean, you brought up a really good point, and I wasn't really sure how much time we had to delve deeply into that. But you're very right to bring that up. There are multiple studies that shows race-related stressors contribute to the overall health and well-being of people of African American descent. And this isn't just something that is specific to epilepsy or neurology. We see that in hypertension, we see that in diabetes. There's one interesting paper that I read recently that discussed perhaps because of our history and the type of foods that our ancestors were fed during slavery or during their enslavement, that somehow changed some of our genetics, some of our DNA, and make us more susceptible to these diseases, even though many of us might now not eat those foods, but it's ingrained in our DNA. And it was a really interesting hypothetical paper, but I do believe that there is some truth to that, because you don't just see that in the US. I'm from the Bahamas, that was also subject to slavery from Great Britain. And our population have the same diseases that African Americans in the United States have, like hypertension, breast cancer. We have high rates of all of these things, colon cancer, just to name a few. So there's something to be said about the history, as well as the stressors currently regarding racism. And you have to call it by its name. Like, I always talk about how racism affects us. Like, I don't talk about the race. It doesn't have anything to do with our race. And we realize that race is a social construct. It's not a biological construct at all. But racism definitely plays a role, not just in the healthcare that we receive, but also maybe our response to the healthcare system. And then Dr. Hamilton and Dr. Mitchell, to answer the question, I think that was in there, like, what can a white doctor do? I think that's important to hear from a patient's standpoint.
Yeah, I mean, I hate to have to follow you, Dr. Ebong, though, but like, I'll just say really quickly. I mean, I think that really listening to them and explaining what is going on is the start, right? And I know that I had several neurological visits where that's not what I got. You know, I went seeking information to for somebody to explain to me what was happening to me, like any patient, right? And I didn't receive that. And so I think that, you know, trust starts by, you know, answering questions and giving information and letting information flow both ways. Because how can, you know, I talk to you and trust you and trust what you're telling me is correct if you won't listen to me, or you don't even think I'm worth listening to, right? That I don't have the capacity for some reason to sort of intake the information that you're telling me, if you give me any at all, right? So I think that's where it starts, really. Dr. Mitchell, you can take it away.
Well, I think you have all said it best. I think it is, you know, listening is so important, and, you know, just that active listening and just showing that you are valued, and, you know, and kind of understanding as well. I think when, you know, with Dr. Ebong and Dr. Ruiz talking about just those additional stressors as well. So, you know, that you're walking around, I know for me, you know, I had to feel this need to prove to people that I wasn't making it up. Right. You know, and so, I mean, I can just walking around with that all the time, just, you know, just thinking, oh, I know I don't feel well, but I'm going to work anyway. I'm going to go to work and I'm going to do the, you know, the best that I can. And, you know, and it's just like, I don't know how many times at a seizure work because I kept going anyway. Even though I knew that I didn't feel well, because I felt the need to kind of, to prove to others that, that I'm a hard worker, or, that I'm, I'll work through anything, or that I'm, that I have worth, and so I think it also understanding that you do have those other constructs that, that your Black patients might be struggling with, that may be different, than others, right? So just say, oh, take your medication. Well, there might be some additional things that are going on with that. So delve a little deeper. So it's not just listening. I think, delving a little deeper to make sure that there might not be some outside things that are impacting them as well.
As a physician, for me, I teach my residents, I teach my students also to look at the language that you're using when you're talking to your patients. Nothing accusatory. I had alluded to it earlier, but I took out the whole non-compliance, medication non-compliance term out of my own vernacular. I mean, that's what I was taught in medical school, that if a patient's not taking their medication, they're non-compliant. But you don't know that for sure. Compliance or lack thereof means that, or implies that the patient is doing something wrong. And that might not be the case. They might not be taking their medication. One, they might not understand why they have to take the medication because you didn't do a good enough job explaining that to them. Other reasons why they may not take their medication is that they cannot afford the medication, and you just prescribe something and they're too embarrassed to tell you that I can't afford this medication. That happens quite frequently in our field, where doctors, we just go ahead, prescribe, and we don't think about the cost to the patient. So you can't just blame the patient and say they're non-compliant. Why are there barriers? And so I've changed my own practice because of my readings, because I was explaining to someone in the chat privately that I've been taught in this field, and I have my own biases against African Americans because of what I was taught. And I had to reteach myself the last few years, and started with medical apartheid. I had changed a lot of the perceptions that I had, that I was taught that our glomerular filtration rate, or GFR, was different. And as you can see, many of you who are in the medical field, with everything that happened with COVID, many institutions are moving away from having separate GFRs for African Americans and non-African Americans, because there's no there's no biological difference between us. That's just an example. So just, make sure that you tread, I don't want to say tread lightly, because I don't want you to tiptoe around your patients and treat them differently from your other patients. Just make sure you treat everybody the same and give them the same respect and empathy, and take your biases and throw them out the window.
Dr. Ebong, I'm
Thank
going
you.
to jump in. On one thing that you said about the patient not knowing about their epilepsy. So when a patient comes to us and I'm talking with them and asking them questions about their epilepsy, I ask, what type of seizures do you have? And many times they can't tell me because that information's not been given to them. And so I think it's helpful for the patient to understand the type of epilepsy that they have, the type of seizures that they have. And that way that they can then gain more information about it and then take more control of their condition. And I think that the more knowledge they have, the better success they're going to have in overcoming the challenges that they might deal with regarding their epilepsy. So just wanted to mention that.
So the floor is open for any other questions. If you have a question, we've got a few more minutes. You can be happy to, or put that in the chat box. I'll be happy to read that off. For everyone that's with us today, I just want to say thank you. Thank you so much for joining in with this, for this very important conversation. I have learned so much from this. I'm going to try to unmute real quick. I have a person asking to add a comment. So hold on just a second.
So you can unmute everyone, is that right, the whole panel?
I'm trying to unmute everyone as well. I'm afraid I'm muting them all though. Hold on, just.
Hello, can you guys hear me?
Perfect, yes, yes.
All right, okay. So I just want to say thank you very much for this talk. My name is Amadou. I'm a PGY4 over here in New York, and I'm planning to go into epilepsy next year. So my question has to do with like disparity in medicine, in neurology in general. So the specific question that I have is for many of the physicians. So I just want to go back and ask, based on your career, right, and all your experiences, do you think the big disparity that we see has to do with first physician bias, right? Like, for instance, is it more likely that a white patient be admitted and to the EMU for like a full workup for diagnosis for a diagnosis of seizure versus a Black patient who would be discharged and left to find a neurologist and go and get, let's say, routine EEG or something like that? And the second question has to do with socioeconomic status, right? So is it, again, is like you just mentioned, Dr. Ebong, there's about 2.5% of all doctors who are neurologists, right? And Black neurologists. So is it difficult to find first a neurologist or epileptologist? And also when they do find those providers, is there a disconnect between, let's say, the patient's insurance, like if they have insurance or they don't have insurance, will they be seen by the appropriate physician? Thank you again.
Well, there is one thing, I mean, I can mention just something about this is in general for me. I choose to work in an academic center because actually at UK, I don't even look, I mean, I have staff members that will look at the insurance. I like to treat, even without insurance, we treat everyone. That's what I tell my patients. That should not be the barrier. We have, but again, every institution or every office may have different, different rules. So I can't speak for everyone. But I know at the University of Kentucky, we just treat everyone with or without insurance. If this is the insurance question. So I don't know, if you would like Dr. Ebong add anything about that. I think the problem is that we see that there is a disparity in care. And of course, we believe there isn't, and I hope, that my group, my colleagues are doing a great job with that. I mean, I know we have patients and, we discussed with Dr. Ebong, she mentioned that African Americans are reluctant to have epilepsy surgery, refractory patients who have refractory epilepsy surgery. Of course, I have several of my patients who are African American who had epilepsy surgery. But I don't know, and Dr. Ebong mentioned another situation. I think today you saw a patient who had levels of anti-seizure medications who were very low, was seen by a different colleague. And this was never addressed, and that's unacceptable. And apparently this is a recurrent problem. All the levels were low. And why this was not corrected? This is something that's, I don't know, Dr. Ebong, if you want to share that experience. That was very upsetting to me to hear that. It's almost like, the humanity, there is no, we consider like two different, one has humanity, the other one doesn't. I mean, it's very, very difficult even for me to conceive that this is happening, but it is happening. The reality of it is happening.
Thank you so much for your question. Dr. Is it Kamara? Okay, thank you so much. And thank you, Dr. Bensalem. Just to wrap up that experience that I had in clinic, I was very shocked. One, because you can tell that the patient was actually taking their medication because they had blood levels in their blood of this particular drug. It was just not therapeutic and they kept having seizures. And the patient just didn't understand, I'm taking my medication, but I keep having seizures. And so I just did a chart review and reviewed back for 3 years. And for 3 years, every time they were coming to the clinic, the blood levels were consistently low. And so that's telling me that, one, the patient, like I said, is taking the medication, like they're saying, but then the medication wasn't adjusted or optimized, and no one told him. And then just going on, you know, as the encounter continued, he became tearful because he said, I really don't understand what's going on with me. And this was supposed to be a follow-up encounter because this patient is established, but I took an hour with the patient and I gave printed information. So I think just taking the time to explain and understand, take time to explain so that the patient can understand what's going on. That's, you know, the first thing to do. And it does sadden me because I have quite a few African-American patients who have similar stories. I have one recently who just got diagnosed after being in the system, and it's not really his fault. Nobody ever really took the time to say what an EEG was, because even when he met me and I wanted to do an EEG, it never had one. He said, doctor, I don't want to be a guinea pig. And he's telling me, who's also a black woman first, but also a doctor, he's skeptical of me. And instead of just saying, well, just don't do it, I had to explain in the simplest terms ever that the EEG goes outside of the body. It's just stuck to your head, that we can read the brain waves so that we can determine whether or not you have epilepsy. And finally, we got the answer. And he was also, you know, tearful. So again, just taking the time to explain. And I'm not saying that this is all Black patients, but patients also who may have learning disabilities or who don't understand, just take the time out to explain to these patients. Now, to go back to your original question about, you know, what should we do in terms of, we had a question related to Black neurologists, because you had mentioned the proportion of Black neurologists in the country is 2 to 3% versus the general population. Realistically, it might be difficult for all Black patients to see a Black neurologist because that's unlikely to happen. So that's why we need allies, physician allies, to ensure that they're competent enough to see and treat patients, all patients, regardless of race and ethnicity. But at the same time, I am passionate about increasing the number of future Black neurologists, Black physicians in general, but Black neurologists. Our department recently partnered up with a local high school here in Lexington, Kentucky, and we are encouraging them to pursue fields of neurology and neuroscience. So hopefully longitudinally in 10, 15 years, we might have, you know, neurologists who are Black coming out of this small cohort. And I think if everybody puts that amount of effort into educating the next generation of underrepresented students and encouraging to pursue the career, we'll see our numbers increase and change for the next generation. Other things that I think that we can do as a people in general, like I said, that there are not enough of us to treat everyone, but there are enough doctors in general to be mentors, like mentors a Black student or mentor a Hispanic student or any underrepresented student, encourage them to pursue this field. We need more of us, we need more of everyone. Like everyone wins when medicine is diverse and when medicine is inclusive. We win as practitioners because we appreciate each other for our differences, our cultural beliefs, our different ethnicities, but the patients win because they get better care when they have physicians, regardless of race and ethnicity, who care about them. So, I mean, I know this sounds, you know, so kumbaya, so
no, it's not.
but that's how I feel. I think that we all need to help each other out so that, you know, we can get to where we are, so we can stop going to medical school, so our future students can stop going on their tours in medical schools and seeing the walls with just old white gray hair men standing up being the deans and chairs and whatever have you. Like hopefully a chair looks like Dr. Bensalem-Owen in like a few years.
No, thanks. But you're right. You know, we have to remember, I think as physicians, healthcare providers, we have to remember, first, I think we should go into this business because we care about humans. It's not that, I think sometimes I hear people going into medicine for the wrong reasons. I was like, well, if you want to do that, go into finances, don't go into medicine. I think medicine is a calling, and you have to care about other human beings. That's just about humans, you know, and caring and helping others. So yes, but yeah, thanks. Thanks for everyone. I see the group is getting smaller and smaller. It's Friday at the end of the day, but I think it was fabulous to have such a great group. And I recognize several faces and names and others. I'm so happy to see that we have colleagues from outside, from New York, New Jersey. I think that's amazing. We even had a representative from the Epilepsy Foundation National joining. So that's wonderful. And thank you, Dr. Kamara, for joining us. That's great, and wish you great success for your future career in neurology. Beth, I don't know if you have any final comments, closing comments.
I just want to thank everyone for being here with us today. This has been an enlightening experience. I know we planned and went through the planning of this and the marketing of this, but this has been probably one of the best sessions I've sat on since the beginning of the pandemic. So this has been wonderful. Thanks to all of our panelists that have been here today to talk. I'm just very thrilled. Deb, do you have any last words you would like to add before we let everyone begin their weekend?
Well, I just want to echo what you said, Beth, and thank you, especially to Dr. Mitchell and Dr. Hamilton.
Yes.
I really appreciate you being, a parent of a child with epilepsy. I appreciate you sharing your personal stories. Yes, and and carrying on this conversation. And Dr. Ebong, Dr. Bensalem, Rachel, thank you so much. Dr. Ruiz, thank you so much. We truly appreciate your involvement. Beth, great job. Thank you.
Goodbye, everybody. Have a great
Goodbye. Have a great weekend.
Be healthy, stay healthy, be safe. Bye.
Bye-bye.
Bye-bye.